the last time you have to listen to me, so that's the good news. But anyways, before we start the learning from defects, and I think this is a really important point, and hopefully we'll have a little bit of fun with it. But one of the things I wanted to comment and to just congratulate you is I thought those two presentations were just excellent. And I find that I learn more from other people than I can give you. And I thought they were great. I wanted to highlight just a couple things for you to think about because as you heard the two presentations, what did you hear? You heard recurring themes, did you not? We talked at first about, I heard over and over again from both those presentations about leadership support, which is so important. And we kind of heard that theme. We also, when we talk about learning from defects, one of the things that Tiffany presented, and I want you to keep this in mind, is higher order problem solving. So she didn't just say, the nurse has to look at this. She designed a sheet so that what did we do? We hardwired those practices. And that's part of what learning from defects is all about, is higher level problem solving. How are we going to put things together because they might impact other patients? So I kind of heard that again. The themes keep recurring, and so some of the issues that come up are really common to all of us. The other issue that I heard loud and clear was physician engagement, right? Everybody said nursing's on board, but physician engagement is a little more difficult. So when we talk about our sustainability plans, when we talk about learning from defects, what are we going to do in terms of physician engagement? Because they're really, really important. And one of the defects that we see, and someone brought up to me, was the fact that if the doc gets called in the middle of the night by a nurse that said, this patient can't void, she needs a catheter, what's the doctor going to say? Put in a catheter, right. So again, that's where when you think about learning from defects, think about all those things that occur and reoccur, because they're really important. Other thing we talked a little bit about is the idea of checklists and things like that, and I heard that this morning. The one thing I want you to keep in mind with checklists, because it's kind of a moderate level solution, one of the things to keep in mind with checklists, though, a checklist is only a checklist unless the people using it are truly engaged. And I remember, actually, in my very early days of nursing, and I became a nurse at 19, we took patients to surgery, and we had a surgical checklist. You know, did they have the rings removed? Did they have it? I mean, it was pretty basic. And you know what people started doing? Just checking the boxes. You know, so when you start learning from defects, when you put in these kind of solutions, think about the cultural aspects because it's more. And I heard Chris Goschel speak, and many of you might have heard her on content calls, and she's really the nurse behind the Peter Provost and the CAUTI project. And she said the most disappointing thing to her when all the data was published and presented was that everybody got hung up on the checklist. And she said, it's not the checklist that changed things. It's the way we worked together, it's the way we did things. But somehow, especially the lay press, really likes to hang on to a checklist solves the world. So I did hear that, and I just wanted to, again, commend both those teams. What great presentations. And I actually asked Tiffany to send me her sheet and a couple of her slides. So remember, all of you have these great ideas, and that's the nice thing about it. So, you know, when we talk about learning from defects, we talk about a concept called sense making. And if you get into the CUSP toolkit, you'll see it all. So I did not go into it, but I think it's really important when we talk about defects that we talk about this idea of what are we talking about. And so to talk about a defect, the concept is it's a failure. And we know in manufacturing it's pretty easy to find out. So what's a defect in healthcare? Well, a defect in healthcare is harm, right? An infection may be harm. Those of you in quality know if you take off the wrong leg, it's harm. We leave a retained sponge in a patient, it's harm. And if a patient gets a healthcare acquired pressure ulcer or fall, that's also harm. So all these things are considered defects. The one problem with healthcare healthcare-associated infections, which makes it a lot harder to think about defects, is we all oftentimes don't have a time and we don't have a cost. So just as an example, and this is why your problem solving is more difficult with healthcare-acquired infections. So if Dr. X uses sponge in the patient, and the patient comes back, and all of a sudden they have to open it up, and they find this routine sponge, we know when it happened, right? We know it happened during surgery. We know who was there, right? We know the OR team and the physician. We have a limited number of people who are responsible for this, right? So when we start to do our root cause analysis, or when we start to learn from defects, it's a much narrower path to go down. Now, if I have a catheter-associated urinary tract infection, it's a lot tougher. You know, who ordered it? Who were the nurses taking care of it? Was it cared for appropriately? When did the infection happen? We don't have all those answers. So you're really going to have to do some problem solving when we deal with this. So the other concept is, how do we identify errors? And one of the things under the cost learning from defects is that if you continue to do status of safety issues, and I've heard about the status of your catheter, not only your outcome measures, but your process measures. Michelle highlighted some data. All of those things are part of your safety assessment, because you know how well you're doing. So think of that as a defects. And then the tools that we're going to use are the learning from defects tools. So we have that in front of us. So I talked a little bit about first order versus second order problem solving, but I think this is a key concept, and I don't want people to lose sight of it. So first order problem solving is recovery, okay? For example, I'm inserting a central line and I don't have the right equipment here. Something happens. And I have to send somebody out to get it. You know, we didn't have extra catheters. And so all of a sudden somebody brings it in, or a patient gets a catheter-associated urinary tract infection and we treat it and that patient does well. That's kind of first order. We get the supplies, we get the treatment, we react. Dr. X forgets to do something and the chief of service writes him a little note that says, Dr. X, you didn't do X, Y, and Z. From now on, we'd like to make sure you order the appropriate antibiotic on your patient. That's first order problem solving, right? Because it's a specific doctor, a specific thing. Second order problem solving is what failure from defects talks about. So when we talk about second order problem solving, we have to look at the issue, and it's no longer Mrs. Jones got the catheter-associated infection. Dr. Jones, you didn't order the right pre-op antibiotic. But the question you have to ask yourself is, how can I keep this from happening to someone else? So most of the time, when errors occur, when defects occur, it's more of a system issue than it is a personal issue. Now, once in a great while, we know it's a personal issue. We have a doctor who's so belligerent he won't do things, or as Tiffany pointed out, she has some older physicians that they've always done it this way, and you have to have an order for things, and I love the suggested solution, talk to other people, because where they trained isn't doing it that way. But we need to ask ourselves, how do we address future failures, and does what happened, could it happen to someone else? And that's the question you want to constantly ask your team about. And I'll just give you an example that happened at our CUSP meeting yesterday. And as I said, we talked not only about CAUTIs, but we had a discussion, and on the surgical unit they had gone almost 2 years without a central line infection, and they got their first central line infection. And as our second speaker said, it's really, really distressing. And as they're going through the case, the patient had a perm cap inserted in radiology, and any of the permanent lines our IV team and PIC team cares for. So they care for PICs, they care for those, except if you're in the ICU. They do the dressing changes, they do all those things. And they said the PIC team, the IV team didn't even know about this patient. They had no inserted in radiology, nursing thought 15 minutes. No one had even been up to change those dressings. Now, I'm not sure it was possible, so they said, well, we alerted the PIC team about this. And we told them about it when we found out the problem. Is that a first order problem solving? Yeah. How are we going to prevent this from happening to the next patient, right? That's the question your team needs to ask when we learn from defects. If the team that's supposed to be responsible for changing the dressings and assessing it does not know that someone got a catheter placed somewhere else, because usually the PIC team is the one inserting, but because this was a firm cath, it wasn't a PIC cath or a PIC, how do we get that information? So when you're thinking of learning from defects, think about that. Okay, so the fourth question, how many people here, first of all, use the learning from defects tool? A few of you, okay? We'll talk a little bit about the tool and why sometimes it's difficult to generalize it and how I kind of narrowed it down. So the first question you ask yourself is, what happened? So we kind of know what happens, and those of you in the quality arena know we ask that question. Second thing is, why did it happen? So you have to begin to ask yourselves, why did it happen? Why did someone fail to communicate to someone? Is it a system problem? Third question is, what will you do to reduce the risk of recurrence? And then fourthly, how do you know the occurrence is reduced? And that's what we don't do really well. So I just want you to take a few minutes. We're going to kind of go through this before I show you the films. So with relationship to CAUTI, look at your own organization, and I want you to look in general, but in your own organization, now call on somebody. So, you know, if you put your head like this, you'll get called on. List all the defects in your own organization that have the potential to contribute to a patient having CAUTI, getting CAUTI. So think about your own organization and where are your gaps right now? And I'll just give you a couple seconds. You can kind of do it on a spread paper, or I'll just call on you, or maybe you'll volunteer. So I just want you to think of that, because we've heard these great presentations this morning by the teams. We've heard what they said might be some of their issues, and we've kind of heard about sustainability. So I just kind of ask you to think about yourself, what you've learned this morning, what you know, where might be your defects. And when you identify those defects, discuss your 3 greatest risks. So right now you're looking at your own hospital, you're not looking at what you learned. You're looking at your own hospital, and what do you think with the defects that are going on? What are your 3 greatest risks? And then, based on your experience, rate those. So I'll just call on someone to see what their highest risk is, and then I'll maybe ask if some people would comment on that. Does that make sense, first of all? Directions clear? Okay, because, you know, I get excited about this, and they're going to say, I didn't understand what she said. You see, now this is good because you guys are in the middle. I'm from New York, I talk fast, and I gave a lecture in South Carolina, and you know, they talk real slow. So, and I love it. I love the Southern accent, but, you know, I'm kind of a little faster. So if it's not clear, raise your hand, okay? All righty. And so that was pretty easy. I'm going to, do you want to share with us? And I'm sorry.
Because I
Maria, because I read your face, because I know you have a risk.
Oh, challenges? Oh gosh. Well, several. When physicians buy into, especially the ICU, they insist that we want accurate diagnose. But yeah, for the ICUs, physician buys.
Okay.
We want accurate diagnose.
Okay, and we heard that earlier. Who brought that up? The accurate I&O. So physician buy-in, they want the patient to have a catheter because they want accurate I&O. You know, I heard one organization say that the literature says that weights are just as good in terms of output, that if you're weighing the patient every day, why do you need that I&O? Because half the time people spill the urine when they're measuring it? No, I'm just kidding. But, you know, so that's the thing. So you figure that's a risk primarily because the catheters get left in, right? So anybody got any thoughts on that? If we were gonna identify problem solving with that particular issue, what would be some of your thoughts on how we can change that? Anybody have any ideas on that?
More education for the physicians.
Education of physicians. You might show them some of the literature. One of the things I find with physicians, and I'll just share this with you, is now I'm an infection preventionist, so obviously I go to the infection prevention literature. If I'm talking to surgeons, though, sometimes I'll try to find something in the surgical literature. Because, you know, they'll be like, yeah, those ID docs, those IPs, they don't know what they're talking about. So now you get a surgical journal and you show it to them and it's like, did you know we're supposed to time our antibiotics? No, I'm just exaggerating. But all of a sudden, so we all kind of get things. So I would use their own literature as an example, and I would pull out some things that talk about weight or about things that might be. And I find there are some really, for ICUs, I find there are really good articles in critical care medicine. So I would ask you, again, when you're thinking of educating physicians, go outside your comfort zone and begin to research their peer review literature. Because in my mind, I'm going to look at APIC and SHE because those are my journals, those are my Bible. But if I'm a surgeon, I may want to see something in the other literature. So that might be one way we would address that issue. Just one more. Anybody else want to give me an idea of a risk that they've seen? Tiffany brought up ancillary departments. So Tiffany is bringing up the fact that maybe with relation to CAUTIs, I have problems with the ancillary department, and it could be that I've educated all the nurses, everybody's doing a great job, but all of a sudden the transporter comes in, lays the urinary bag on the patient's bed, and has no idea, or doesn't wash his hands, picking up the urine bag. So what would be some of the problem solving or learning from defects that we can learn from that particular example? Thoughts? Anybody have any solutions to the ancillary departments? Well, education's one. Having them be part of the outcome, okay, because we want to connect the dots for them, okay? So if we're reviewing a case of CAUTI, and that patient has been transported to different places, and we're talking about all the potential things that might happen, because we don't know when this has, how about we invite transport to that? You know, so it's not only education, it's engagement. So kind of think about those strategies when you're talking about those things. So those were a couple good examples. Thanks. Okay. Identify why defects occur. And in this particular slide, the competency plan is not followed. One of the things I've heard a lot about CAUTIs on some of my coaching calls is some hospitals require a competency model. And some hospitals even have labs because, or simulation, so to speak, or not true simulation, but they're going to see up nurses knowing how to insert them correctly. So that might be one thing. Focus was on EMR implementation. Now, I've had some conversations with all of you, and we know that we love and hate the electronic medical record. And what they will tell you if you have our vendor is it's all going to get fixed during optimization. Except my problem during optimization is number 243 on the optimization priority list. So we've got some things to go. So that's it. Daily catheter patrol was not consistent. You know, one of the things that I'll just challenge you, because I've heard a couple things about having someone be the catheter not see and all those types of things. One defect, one potential defect is when the catheter Nazi gets sick and has her gallbladder out, who's going to take over for that? So be sure when you're looking at learning defects that you build a backup. Never have it. And then our prevalence rates are up. So those are things. Can't see this very well. It is in the CUSP toolkit, but if anybody wants it, I will send it to you. Because I start my learning from defects with a CAUTI prior to going to the learning from defects tool. Because this is a really, and this actually, I believe this particular example came from UNC. I have a simple one, but it's really when was the catheter inserted, what was the appropriate reason, were there any known breaks in technique, any of those types of things. So all of those types of things, when you're looking at your CAUTI, you can start there, because what are those? Those are the technical components. And it gives you a nice little checklist that you can go down through. So it's a pretty hefty checklist, but I would encourage you to use something like this to examine your CAUTIs, and then to go on and look at that. So here's a scenario I'm going to give you. Your surgical ICU has done a really great job with CAUTI. However, your IP team has recently reported that 2 surgical patients have developed CAUTIs this month. Now, when we looked at the chart, the patient did, the surgeon did order the urinary catheter. The surgeon ordered it as appropriate. We don't have any standard order sets in this hospital for discontinuing. So, at least for this particular general surgery procedure. So what they thought was done is they had cardiac order sets and they have orthopedic order sets for the hips. They don't have any for these large surgical cases. And after review, it appears that all insertion criteria were met. Obviously, the patient needed. No breaks of evidence and technique, nothing wrong, nothing like that. Both patients met criteria for CAUTI on post-op day 4 and 6 respectively. And they said, well, we make daily rounds in the ICU, and we always ask, does the patient need a catheter? Does the patient need a line? And they're documented appropriately. And on this, it says, and down below, if you hit the screen for some reason, assessment of ongoing use for invasive devices, and the doctor has yet asked for a urinary catheter because they're making multidisciplinary rounds in the ICU every day. Okay, what's wrong with this scenario? What do you see? What do you think the problem is here? What's that?
Catheters were in too long.
Yeah, but the doctor said they still needed the catheter.
What was the reason?
And that's our high-level problem solving, and that's the challenge for you guys, because we'll see a lot of ICUs, and I looked at my own with CLABSIs, CAUTIs, vents, and everything, is the doctors have this wonderful checklist. Need for catheter, yes. Need for vent, yes. Need for this. But you don't see any logical thinking, or you don't see any criteria for removal like we saw in the discussions this morning. So just because someone makes daily rounds and thinks the doctor needs a catheter or thinks they need something is not necessarily the case. And you know, one of the wonderful things about IT, if you have IT support, and Tiffany brought up one example earlier, is the idea to hardwire those criteria so that if you say this surgical patient still needs its catheter, the doctor, as he's making the multidisciplinary rounds, still has to identify the line behind it. So, you know, these quick fixes sound like they're great ideas, and honestly, this particular case is my own surgical ICU, so I took it from a reality. And I'm looking at the documentation. It needs catheter, needs urinary, and so I picked up some ideas from you guys today too. So do remember that when we're talking about things. Okay, so we have the learning from defects tool. And if I was going to take that on here, you're going to look at interventions to reduce the risk of a defect. And then you're going to look at specific interventions. So that's it. You have it on your yellow sheets. I just wanted to show it up here. One of the things I want to point out to you, and this is probably the most important piece of information you're going to get today when you problem solve, is you have high level, medium level, and low level interventions. And 90% of the time, we put into place low level interventions. What do I mean by low level interventions? Be more careful or educate. How many times have we said educate, educate, educate? Education helps, but it is what we call a low-level intervention. Why? Because adult learners can't always hang on to those concepts. So let's look at the high-level interventions, and this is where you really need, when you're thinking of learning from defects, this is where the paradigm shift comes in. When and where can we put in high-level interventions? A forced function is a high-level intervention. So I can't order this unless I do something else, okay? We have forced functions all the time. For example, your lawnmower. I have to, if I let go, it's going to stop. I can't, keep going because I have to hold on to that little bar, not that I mow the lawn. Usually my husband does, but I try once in a while. I can't hold on to that bar. But my friend has a husband who doesn't like the fact that it turns off if you stop it. So he's jury-rigged the bars. So I go anyways. Now, you'll always have people who will, go against the forced function. And automation, whatever you can do automated is really, really helpful. And this is where we really need to go collaboratively and nationally and universally. I think it's really important that we think about automation. And one of the things I heard today was that people can't even get line dates from their electronic health records, which really seems ridiculous, and no one can. So we need to get to automation. Medium level interventions are protocols, and they're really good. So we put a protocol in place that everybody knows and everybody follows. And checklists are medium level interventions, and rules are medium level. And then the lowest level of intervention is education, or just going out to somebody and saying, don't do that again, right? Because it doesn't affect other people. And not that education is not important, but usually education alone will not solve problems. So do keep that in mind. So with that, I'm going to show you a couple little videos here. Hopefully I'll be able to bring them up. Let's see. And we'll stop it and use our Learning from Defects tool, because I think these videos really nicely point out some of the things. So I'd like you to kind of use the tool as the video is going along, and then we'll kind of comment on those.
All symbols? Okay, at last month's staff meeting, we watched a patient safety video and we discussed some stories of patient harm. We also introduced the comprehensive unit-based safety program's staff safety assessment form to the staff, and we asked them to fill it out in order to identify patient risks in our unit. So here's some of the responses that we received so far. 3 of our nurses and 2 of our unit clerks have shared the same concerns. So I'd just like to read the ideas out loud and make sure that we're capturing your thoughts correctly and then categorize them. So several of you are concerned about our immediate post-op patients being at risk for falls, and some of you are worried about the number of patients that we're seeing with post-op infections, and even noted that there seems to be a number of patients who needed to be readmitted to our floor because of them.
Well, related to infections, we seem to be having an ongoing problem with antibiotic use beyond the recommended time frame of 24 hours post-op. And we all know that this could increase the risk for the development of antibiotic-resistant organisms.
Yeah, good. Okay. Another concern is that pharmacological venous thromboembolism, or VTE prophylaxis, is not being ordered post-op. And we have had 2 patients in the last 3 months who developed a clot that delayed their recovery.
Marie, we talked about that in our last medical staff meeting. Some surgeons do not agree with the recommendation for pharmacological prophylaxis. Let's table that issue for now.
All right. Now, several nurses were worried that we've had some admissions during shift changes over the past couple of weeks, and the clerks were concerned about this too. One of our newer nurses said she had an admission just before shift change last week. It was really hectic. She felt as if she had forgotten to pass on some important information. And we all know that poor handoffs can lead to a lot of problems.
Yes, and I wonder if poor handoffs are the reasons for some other concerns I've had with antibiotics. We've seen several doses that were not given at the appropriate time.
These are all concerns we need to pay attention to, and I think they should be added to our CUSP Status of Safety Issues worksheet. There's a team working on falls. I'm working with the surgical committee to address compliance with pharmacological BT prophylaxis. So let's focus on how we use antibiotics, including stopping them as appropriate.
I agree, but I would like to recommend that we put handoff communication at the top of our list too. There appears to be a lot of patient information that's not being communicated from one nurse to another.
Well, I hear you. We may find that handoff communication is the cause of several of the defects we are experiencing. Let's start with antibiotics, and we may end up with handoff communications as a contributing factor.
Okay, sounds good. So discontinuation of antibiotics 24 hours past surgery really is a concern. So let's talk about this more at our Learning from Defects meeting.
So why don't we go ahead? What were your thoughts on that particular video, and what did you learn from that? What's that? Yeah. And so what was happening there as we talk about focusing, and don't get a lofty part. And I think when you look at a video, what you need to learn in using the tool, when you're looking at a video, what's happening? Well, doctors don't prescribe DVT prophylaxis. What's that all about? So what we find is that a lot of times in all of our settings, it starts working that way, does it not? But what did the nurse do? I want you to think about that and think about the Learning from Defects tool. What did she do to kind of turn things around?
But a key thing, she didn't get tied up in each individual comment. She kept it moving forward and didn't try to defend it.
Right. And as coaches, that's a strategy. What else did she do? She kind of brought it back around to antibiotics, didn't she? Because we started, there were all these types of things. And so part of your job when you're learning from defects is what? To begin to get a little more specific when you look at these tools. So she said, well, could handoff communication be part of the antibiotic? Let's look at the antibiotics. So again, she began to help them narrow down what they were going to look at because there's a host of problems. And you know why this was so helpful? Because we can probably video our organizations sometime and have that conversation. And we talk about multidisciplinary collaboration, but oftentimes you get some doctors in the room and you'd like to get a muzzle for them. So you begin to say they need to be involved, but then when they do get involved, you want to muzzle them because they have their own hidden agenda. So we saw that, and clearly the surgeon there. So these are some examples, and what this tool is going to do is kind of help you really focus on these types of things. Ask the questions. She's starting to use this tool unofficially to begin to hone in on particular issues. So I wanted to point that out. Okay, the next one here that we'll use, and thank you for doing that. I failed technology. Actually, I failed art, gym, and music. That's why I did this. No, very good. Okay, we're going to talk about...
Welcome to the Learning from Defects meeting. We want to discuss a particular defect that the team identified, and that's discontinuation of prophylactic antibiotics. So to review this problem, we'll use this Learning from Defects tool and focus on these main questions. What happened? Why did it happen? How are we going to reduce the chance of it occurring again? And how do we know that it reduced the risk? So let's talk about the first question. What happened? In reviewing the events and talking to the team, we have missed discontinuing antibiotics with 20 surgical patients over the last 2 months. So I've selected the latest patient to review, a patient who had a cholecystectomy. He received his prophylactic antibiotics within 1 hour prior to the surgical incision, but the antibiotic was not discontinued within 24 hours post-op. And in fact, the chart says that he got 2 more doses before the mistake was caught and the antibiotics were discontinued. Now, we all know that that's a problem because that could increase the risk for antibiotic-resistant organisms, and we have seen an increase in readmissions for post-op infections. So next is question number 2. Why did it happen?
I remember Mr. Smith. He was the elderly man from Florida with lung cancer who arrived in the unit after a late lobectomy. We went back and checked, and we couldn't find a standing order from the ICU doctor to stop administering antibiotics. So, unfortunately, the antibiotics were continued, even though they weren't needed.
And we've talked before about the problem of poor communication during handoffs, so even if there was an order to stop, it could have been missed.
We could have an automatic stop order generated from the pharmacy for our post-op patients.
Okay, so we've just named several contributing factors here. Number 1, no standing discharge physician order. Number 2, lack of effective communication at handoff between the ICU and the floor. And number 3, no automatic stop order generated in the pharmacy. So how can we reduce the chances that this will happen again?
We need to flag the steps in the Surgical Care Improvement Project or the SCIP protocol in the medical records. So when we hand off care on the floor, or if there's a shift change on the floor, everyone knows when the patient's antibiotic needs to be stopped.
So we can write a protocol or standing order and get the surgical committee to approve it so that we have a standing order to stop the antibiotics.
Well, we could have a pharmacist do a double check and monitor the surgical antibiotics to make sure they're stopped, or automatically generate a stop order in the pharmacy.
That sounds good. These are some great ideas. So let's prioritize these. And how well do we think that this specific intervention is going to solve the problem, and how likely is it that the intervention is going to be implemented and executed? So we'll start with putting flags in the internal medical record for the SCIP protocol. So let's have a team discussion and then prioritize this. Thanks very much, team. That was a great discussion. So it looks as if our 3 priority interventions here are to 1, develop a standing order for stopping antibiotics and assign a pharmacist to monitor these. 2, we can generate an automatic stop order in the pharmacy. And 3, we'll need to talk a bit more about improving effective communication at handoff. So, what needs to be done? Who's going to be responsible? And when are we coming back together to follow up?
Well, I'll put my name there beside number 1. A standing order for discontinuation of surgical antibiotics. I'll talk to my surgeon colleagues at our next department meeting, and we'll agree to a standing order that you can take to the surgical committee. Our next meeting is next Tuesday, so I'll get back to you by Wednesday.
Okay, and I'll be responsible for identifying a pharmacist to monitor the antibiotics. And I'll work with my pharmacy director to automatically generate the stop order in the pharmacy. I'll need to speak to some of my colleagues as well. I can get back to you by Wednesday too.
Great. Well, we have a staff meeting next week where we can follow up on this conversation. Thanks, everybody.
So anyways,
In our last learning meeting,
let's stop now because we're out of time and we will
and
discuss
if you
this.
all remember that we
It does go on, and these tools are available on the CUSP website. So I don't want to lose track of time for the next presentation. But what did we learn from that second meeting that was different than the first meeting? Did we hone in on specifics? Did we think of some higher order problem solving? We thought of automation, we thought of some things. So do use this tool, because what it will do is help you kind of hone in on things. So often we get kind of general. So it said, we're going to do this, we're going to do that, we're going to do that. And the interventions, many were technological, many were looking at automation, many were looking at hardwiring practices, but they also assign people and assign time frames. Do we always problem solve that way? I don't always. And so what this hopefully will do, and I'll encourage you to look at the other videos, is to be able to use the tool that's in front of you and kind of think about that when you're talking about things. So if we were talking about, for example, the CAUTI example that I gave you earlier, it would be, do we need to put specific indications so that when the doctor says the patient needs it, we can mark off what the indication is? How are we going to get that done? Who's going to get that for us? If we got someone from IT to work, who's going to own it? and what time frame are we going to get back? So, you know, these were tools we all learned a long time ago, but hardwiring these tools and using them to really be able to learn from where our errors were and to move forward is a wonderful opportunity. So with that, I think we're just about, just a few minutes over, Michelle.
We're fine. What we can do now is go ahead and bring up our panelists.
Great.
And that's Cecile Pierce, Vicki Overding, and Maria Pena. If you come on up.